Okay, I'd like to welcome everyone to part 2 of Module 2, Communication and Practice. In this section, we are going to be talking about some of the different therapeutic models or theories and kind of how those help us conceptualize mental health. So, to start this off, how these different therapeutic theories or models work is they kind of help us understand different therapeutic approaches, why they're important, what are some of the assumptions or focuses that go into those. So assumptions about how the mind works, what's the influence of trauma on the mind, how do different psychiatric problems or diagnoses originate. And then it can help us kind of conceptualize how to discuss these problems and discuss care for patients. Now, what's the role of the RN in all of this? Well, as we discussed previously, the RN isn't going to be actually conducting therapy, but it is important for the RN to be therapeutic. So that's going to include supporting the therapist role, helping the patient kind of explore different ideas, and also having a basic understanding of how these models work or influence basic care. So we're going to start off our discussion with the psychoanalytical model. So the psychoanalytical model, basically it's the idea that this was originally developed by Sigmund Freud, and a lot of this is controversial even by today's standards. A lot of this focuses on basically the motivation of the unconscious. So this idea that deep down inside us, where we can't get access to it, we have all of these conflicts and desires, and they manifest in our life in a lot of different ways. The psychoanalytical model puts a lot of importance on early childhood events, so especially things like relationships with our parents, very early traumas, anything like that is going to be a big focus in this therapy. A lot of this therapy is also based on gaining insight into the unconscious. So kind of getting back to, well, what is the real source of this problem? What is going on underneath all of this? Some of the other terminologies and concepts that we'll come across in this is things like defense mechanisms, the unconscious mind, free association, where a therapist will say some specific word and the patient will respond with whatever word first comes to their mind. Again, this idea kind of getting at the unconscious. Similarly with dream analysis, really free association and dream analysis are not big components of this, but are used here to kind of illustrate that idea of getting at the unconscious. And then transference, which we'll put a pin in for just a moment, and we'll talk about it as we go through the slides. So understanding the conscious and unconscious minds. So with the psychoanalytical model, basically the mind is divided up into 3 sections. So we have first, the id. This is the most primal part of the brain. This is completely in the unconscious, so we don't have perception of what this is going on or kind of what the underlying principles of this are. But the id is based purely on the pleasure principle, meaning that it is all about desires, drives, urges. It is very selfish, and it is very much worried about satisfaction. We then have the ego. So the ego is kind of a balance of the superego and the id. It is kind of our idea of ourself. The ego is based on the reality principle, meaning that it has to deal with the reality of the situation. It has to weigh out different factors and decide what is the best course of action. The superego is kind of our moral guardian. This is almost like our Jiminy Cricket on our shoulder. It's our conscience. It's a lot of the social kind of inhibitions, social mores that help guide us through life. It's this kind of always in our ear telling us what we should and shouldn't do. Again, the ego has to balance out the drives and desires of the id, and then the repression and the structure of the superego to kind of balance out into what we actually manifest and how we interact with others, how we go about our daily lives. Now, defense mechanisms come into place specifically because defense mechanisms are thought to be a way to protect ourselves. They're usually unconscious coping mechanisms that help us relieve anxiety or avoid anxiety. So a lot of times when we talk about these, they are, like I mentioned, unconscious, and they usually are to help us avoid stress or anxiety in some way. Now, defense mechanisms are not always a bad thing. However, when they're used in excess, they can become bad. We're not going to go through all of these individually. There is a document in this module that has all of the defense mechanisms, or all of the most common ones, listed out with some brief examples of those. Really, with these, you do have to have kind of a basic understanding of all of these. For whatever reason, this is something that gets tested on the NCLEX a lot. It's not something that's super duper useful all of the time to your practice, but it can be helpful to know these, and like I mentioned, it does get tested on a lot. So some of these basic ones. Denial would be this unconscious refusal to admit or accept an idea or behavior. Regression is going to be this unconscious reverting back to a younger stage, so a safer developmental stage. A lot of times this is seen with children who maybe are 6 and 7, have gone through some kind of trauma, or maybe there is a death in the family or a divorce, something that has disrupted their safety or their perception of safety in their life. They'll revert back to bedwetting because that's kind of a safer time. They are taken care of. Their needs are getting met in that way. Suppression is a conscious exclusion of an awareness of an anxiety-producing feeling. So this is when we decide, I know that I have to deal with this fight that I had with my spouse, but I can't do that until after my shift ends or until after I complete this test. So it's deciding consciously to exclude awareness of those things. And this is how it's different from denial. You know that those things have occurred, but you are deciding not to deal with them at that moment. Again, this can be healthy when we do it briefly or sparingly. It's when we continue to do it that it becomes a problem. Disassociation is an unconscious separation of ourselves from painful feelings. So we actually kind of detach ourselves from it. We sometimes will go on autopilot, or we'll feel like it's happening to someone else instead of kind of dealing with the emotional turmoil that can come with that. Repression is usually unconscious and involuntary. This is when we actually lose memories of painful events or conflicts. So we actually don't have access to those memories. Projection can be when we are kind of putting our feelings onto someone else. So if I'm having a disagreement with, let's use Mina as an example. Let's say I'm having a disagreement with Mina and I am really mad at her because, I feel like she's selfish. But instead of kind of recognizing that, that maybe some of that is my fault, and maybe some of it is that, I didn't take responsibility for what I was supposed to do, or I didn't coordinate with her. I put all of that on her, saying, oh, well, she's so selfish. She's so inconsiderate. She never thinks about anyone else. She never worries about anyone else's schedule. So I'm not taking my kind of part of that responsibility. I'm putting it all on her. It can also be when we kind of have unwanted feelings. So again, maybe I'm mad at Mina, but instead of saying that I'm mad at her, I'm saying she's mad at me. So I still don't have to interact with her. I still don't have to do things with her, but now I'm blaming her for that falling out. I'm saying, oh, she was the one who decided not to do that. Rationalization is when we use justifications for our behaviors. So let's say that I get a bad grade on an exam. Well, it's not that I didn't study for the exam. It's that the teacher doesn't like me and they're out to get me. That's why I got a bad grade on the exam. I'm rationalizing what happened or what the events were. Intellectualizing is when we start to take too much of an analytical approach to a problem or a situation that we're in. So instead of actually dealing with the emotions of it, we examine it almost like a scientist, like, what's the logical explanation for this? How can I reason my way out of this? So transference, I mentioned that we would come back to this. So transference, again, is something that does get tested on occasionally, and so it is good to be familiar with these terms. So transference usually occurs when you have a patient who is putting some emotions on a therapist. So they are kind of redirecting their emotions that they felt, usually in early childhood, to some type of substitute care provider. So in our picture here, it's a therapist, but this could very easily be a nurse, a physician, a social worker, a case manager, any number of healthcare employees. So the patient, something about the therapist or the healthcare provider reminds them of someone in their life, a parent, a former lover, something about them reminds them of that. So they put those emotions onto them. So, here we have an example where a parental figure laughs at the patient or other people's feelings. Then the patient is reminded of that parental figure in their therapist. And so they think, well, maybe the therapist is going to laugh at my feelings. So this is that transference. They're transferring that emotional experience that they had with one person and putting it onto someone else. So let's take a break and have a question real quick. So this is a little bit of a story, and this will get into some of the types of questions that we'll see on the exam, for example, with defense mechanisms. So Tom and Sally have been dating for 2 years. Sally breaks up with Tom because he cheated on her with Betty. Sally tells her friend Kelly about the breakup with Tom and all of the reasons it's actually a good thing without showing any emotion. Sally is using blank as a defense mechanism. A, repression. B, denial. C, projection. D, intellectualizing. E, regression. So hopefully everyone got the correct answer here with intellectualizing. So Sally got cheated on. She broke up with her boyfriend. But then when she's recounting those events, she's not focusing on any of the emotions that go along with it. She's intellectualizing and almost justifying all of the reasons it's actually a good thing. She's being too analytical about it and divorcing herself from those emotions because those emotions are going to cause some pain. So continuing with our story, Tom continues to call Sally and treat her as he did when they were going out. Tom is using blank as a defense mechanism. A, repression. B, denial. C, projection. D, intellectualizing. Or E, regression. So in this case, the answer is going to be B. So Tom is kind of denying that anything ever happened. He is acting as if everything was the exact same as before, as if they never had a falling out, there was no breakup, and they haven't moved forward at all. So he is denying that any of that has happened. So Betty, who did not know about Sally, tells Tom that she is glad that he feels guilty for hurting Sally. She also tells them that it will take a long time to get over his guilt. Betty is using blank as a defense mechanism. A, repression. B, denial. C, projection. D, intellectualizing. Or E, regression. So here we see Betty is using projection. She feels guilty. Or we can assume that she feels guilty and that she feels like this will take a long time to get over this guilt for breaking up this relationship, for hurting Sally, even though she didn't know about her. And she's putting that onto Tom. She's deciding that she is going to displace her uncomfortable emotions onto him. So now that we've talked about the psychoanalytical model, let's talk about the recovery model. So the recovery model is designed specifically to focus on consumers as the primary agents for control and decision making in their care. So when we're talking about consumers here, this is a term that is used a lot in the recovery model, basically interchangeable with patients. So this originated in addiction treatment, and the idea here is that you want to focus a lot on what the strengths of the patient are. So what are they able to do for themselves? How can they control their situation? What initiative or power do they have? What you're doing is trying to develop hope in the patient so that they can change what they're doing. Two big concepts that we want to cover in this are motivational interviewing and the stages of change. So motivational interviewing, let's back up. Motivational interviewing is a patient-centered, direct approach to enhancing motivation in a patient. So what we're trying to do is resolve ambivalence. So ambivalence is when patients maybe can't quite decide if they should make a change, if it's necessary, if it's worth it. And what we're trying to do is help them resolve that ambivalence. We're trying to help them move forward. So what we want to do with motivational interviewing is use what are known as the OARS technique. Now, this stands for open-ended questions, affirmation or affirming, restating, and summarizing. These are all therapeutic communication skills. These are all going to be kind of used similar ways as we've discussed before. When we're using open-ended questions, this is to help the patient kind of recognize what the problem is, why it's so difficult. When we're offering affirmation, this is offering validation and reassurance. Understanding that, well, this sounds really difficult. This must be really hard. We're offering empathy, but we're also not excusing the behavior. So even though it is really difficult to do, we are not saying that it is okay or acceptable that they've, started abusing a substance, that they've started, engaging in some type of behavior that is not productive. When we're looking at restating, this is very similar to paraphrasing like we talked about before. We want to make sure that we're summarizing what the patient has done. We are drawing connections. We're restating and reflecting what their emotional state is. And then summarizing. So this is where we go over kind of the major themes that we've talked about. We make sure that we have understanding between both us and the patient, and we have a good plan for moving forward on what to do. So the other concept that we want to get in all of this is the stages of change. So with the stages of change, this is basically a model that helps us kind of understand what are the patient's needs in any given stage. So in the pre-contemplation stage, here at one at the top, we have patients basically at the point where they don't know that a change needs to be made. So what we need to help them do is realize that a change needs to be made. We need to raise awareness. When they move into the contemplation stage, this is when they're considering making a change. So they're weighing maybe some of the pros and cons. So what we want to help them do is choose to make a change. We want to help, again, relieve that ambivalence and move forward into what's next, the preparation stage. So this is when the patient is actively planning to make a change. The patient understands that a change needs to be made, and they are trying to decide what that change should be. So what we're going to help them do as healthcare providers is identify what strategies are going to be best for making that change. In the action stage, the patient has already implemented the actual change, and what they need is support. Next, they're going to move into the maintenance stage, where they need to sustain the change. So when they're sustaining the change, again, they need support from staff to troubleshoot problems. And you need to realize that at any point there can be relapse in all of this. One of the things that I always tell people is we need to remember that relapse is part of the process. It is not a hindrance to the process. So keep in mind that relapse is going to be something that comes up. It's unfortunate, but we need to be anticipating it. When relapse happens, what we need to do is kind of reassess what were the goals, what were some of the deficits, what are some of the needs now, and move back into these stages of change. So this can be really important in making sure that we are identifying kind of where the patient is in all of this to make sure that we can help, again, match them up with their needs, what is going to be best for them, what services are going to be best for them. So next we're going to talk about the psychosocial model. So the psychosocial model was originally developed by Erik Erikson, and this focuses a lot on the interactions of the biological, the psychological, the social, and the environmental. All of these different factors that help influence our personalities over a life cycle. The big focus of this is growth and mastery of critical tasks. So when we're talking about critical tasks, what we're talking about is these, the way that Erikson set this up is these dichotomies. So at every level of life, or every developmental level of life, we have a different crises. Again, this is the terminology that Erickson used. We have a different crises that's presented to us. So in infancy, the crises that we have is trust versus mistrust. Can we learn to trust our care providers? Can we develop reliance upon them? Have they demonstrated that they are trustworthy? If we move forward into teenage years, we have identity versus role confusion. This is part of the reason that teenagers will kind of try on different personalities. They're kind of trying to find out what personality matches them best, what kind of fits best for them, what's most authentic. We move into older adulthood, so we have integrity versus despair. Are they able to look back on their lives and see that there was benefit there, that they're leaving a legacy behind? Or do they feel isolated, alone, feel like they weren't able to give back? So again, all of these different crises present different tasks for us to master. And the idea here from Erickson, again, was that this was very linear, that you have to go through each of these steps one at a time, that if you have the negative outcome of one of these, that you have to go back and re-explore that. Like I said, a lot of this is going to focus on growth and mastery of these critical tasks. You need to have a resolution of these developmental tasks. A lack of resolution is going to lead to developmental delays, relationship difficulties, psychological distress. And the big change that we're looking for is resolving these critical tasks, making sure that you face those developmental crises. So moving into our next model, we have the interpersonal theory. So the interpersonal theory was developed by Harry Stack Sullivan. So this focuses a lot on the intrapsychic stress that arises from interpersonal relationship patterns. So when we're talking about interpsychic, that is inside the individual. When we're talking about interpersonal, that's between two or more people. So what a lot of this focuses on is examining and examining our old patterns and learning new patterns of interacting with others. One of the key kind of cornerstones of this is the transactional analysis. So with transactional analysis, basically the idea is that in any interaction with another individual, we are taking one of these three roles, either as the parent or boss, basically the authority figure, the adult, and the child. Now, when we look at how these interact, like for example, in a healthy interaction, when a parent is actually talking to their literal child, they are interacting, they are talking down to them. They are speaking to them in a way that is not as equals, but as an authority figure. This can also happen when we have peers. So, with your classmates, you talk to them as peers, as adults, on the same level. There is equality in the way that you're speaking to each other. This can even be in the workforce or in the classroom when you have a authority figure who is treating you as an adult. They aren't speaking to you like you're a child, but there still is a power dichotomy that exists that changes the way that interaction actually proceeds. Now, the difficulty comes when we start to have these interactions mixed and matched. So instead of having someone speak to you as an adult to an adult, they are speaking to you not as an adult, but as a child. They're condescending to you. They're talking down to you. And this is part of the theory behind kind of re-examining these and then learning new skills with these. Now, the interpersonal model is particularly important to nursing, partly because of Hildegard Paplau. Now, she adapted Sullivan's interpersonal model and applied it specifically to nursing and to the development of the nurse-patient relationship. And she identified some of the key outcomes in that. So looking at Paplau's stages, we have 3 stages of the nurse-patient relationship. So we have the orientation stage, the working stage, and then the termination stage. In the orientation stage, what we're focusing on is assessment. And again, remember, this is going to be ongoing. It is not a single event. This is going to be mostly based on identifying concerns, needs, and the roles that the patient and the nurse will take on. A lot of this is also going to be working in collaboration, so helping not just to set goals for the patient, but determine what goals would be most helpful for that patient. Trust building is a huge part of the orientation stage, making sure that the patient can trust the nurse, that they can share information with them. A lot of this is going to be about managing emotions and providing stability and support. Usually during the orientation stage, the patient is in some type of crisis, whether they were just admitted because they attempted suicide, whether their medications have stopped working and they need to be readmitted for new evaluations. There's going to be some type of crisis, some kind of instability in the patient's life, and it's part of the nurse's responsibility to help manage those emotions and kind of externally set that support and that structure, that's stability that the patient needs. Not taking away what the patient can do, but making sure that we're making up for those deficits. Now, during the working stage, we are still doing assessment. Remember, again, this is not a one-time thing. So during the working stage, we are doing maybe more in-depth assessments, more in-depth data collection, but that assessment is continuing. We're also using selective exploration, meaning that we are focusing on specific problems the patient can focus on and that are manageable, that the patient can actually change. So not focusing on every problem the patient is facing, but selecting one or two issues that you can address and resolve. Again, focusing on what is manageable, what is changeable for the patient, not on all of the things that are outside of their control. We also want to look at having the patient be stabilized on medication, so we're seeing a reduction in their symptoms as the working stage continues, and we're helping the patient move towards those goals that they set earlier on. A lot of this is going to be about promoting change, helping the patient to identify what those changes can be and helping them work towards that. The termination stage is where we are looking at what is the patient going to need post-discharge. The patient's work is rarely ever complete, even though the nurse's part of this process is going to be done. So what we want to do is make sure that we're reinforcing all of the behaviors and changes that the patient has made, and then focusing on what is still needed. What do they need to do after the nurse-patient relationship has ended? And part of this is going to be reviewing discharge instructions, making sure that the patient understands what still needs to be done, and managing some of the emotions that come up with termination with the end of this relationship. So let's look at another question. So question 5, according to Paplow's stages of development of a therapeutic nurse-patient relationship, assessment should A, be completed during the orientation stage, B, continue throughout the orientation and working stage, C, be conducted during the working stage after trust has been established, or D, be an ongoing process through all 3 stages. So hopefully everyone got this as D. So remember, the assessment is going to be ongoing. We are always assessing and reassessing what the patient's needs are, what we need to plan for and anticipate. So the next model that we're going to talk about is the cognitive behavioral therapy model. So the two kind of pioneers of this were Aaron Beck and Albert Ellis. These two gentlemen helped kind of found a lot of the foundational work for CBT, and honestly, CBT is going to be one of the most common therapies that you'll run into and kind of one of the most common basis for therapy. So CBT focuses on the idea that individuals are going to have both rational and rational and irrational thought patterns. These irrational beliefs, or otherwise known as thinking errors, then produce maladaptive emotions and behaviors. Because we believe that these feelings and this irrational beliefs or irrational thinking patterns are reality, we then have problems kind of dealing with what the consequences of that are. The focus of this is about challenging those irrational thoughts and beliefs, increasing responsibility for our own emotions and our thoughts, and eliminating those self-defeating and maladaptive behaviors. A lot of times what you'll see used really frequently is the cognitive triad. So this idea that our behaviors can influence our emotions and our thoughts. Our emotions can influence our behaviors and thoughts, and our thoughts can influence our behaviors and emotions. So we have here the cognitive, the thoughts, how we think about things, and the emotions that we're feeling, and then the behaviors. So we can't always change what emotions we're feeling, what emotions come up with something, but we can change the behaviors that we're doing and the thoughts that we're having around them. And that's why CBT is cognitive behavioral therapy, because a lot of it is dealing with those emotions that come up from the irrational thoughts or the maladaptive behaviors. So some common thinking errors, just to give you examples of these irrational thoughts, can be things like black or white thinking, otherwise known as all or nothing thinking. This idea that, let's say, for example, well, I either have to get an A or I'm going to fail my nursing program. Well, there's a lot of variability between that. There's a lot of gray area in there. And so kind of challenging that idea, well, is it possible that you could get lower than an A and still be a good student? Emotional reasoning, this idea that because I feel like something is true, it must be true. Well, because I feel like my professor doesn't like me, well, then they must not like me because it feels that way. There's also jumping to conclusions, and this can also be known as catastrophizing. This idea that, well, if I don't do well in this course or during this semester, then I won't be able to graduate on time, which means I won't be able to get a job, which means that I will die penniless in a gutter somewhere. Again, this is jumping several steps ahead when really we're not focusing on kind of what is going on now. There's also a mental filter. So this idea that we're only taking evidence that agrees with what we're already decided is the truth. So, I must be a bad student because I got a bad grade on this one exam. Even though I've done well on all of the other exams, even though I have, an A- in the class, I must be a really bad student because I didn't do well on this one exam. So another part of this, or challenging these thinking errors, is cognitive reframing. So this is a two-step process. First, we identify and disrupt the irrational thought patterns, so these maladaptive thoughts or these thinking errors, and then we present positive alternatives to what we're experiencing or what ideas are happening or what emotions are coming up. So instead of kind of accepting those thinking errors as reality, we challenge those, just kind of asking exploratory questions. You said that if you don't get an A in this class, that you feel like you're going to be a failure. Is that really true? Do you feel like if someone else told you that would make sense? Is it possible to get less than an A and still be a good student? Again, just kind of asking these questions to help the patients challenge these irrational thoughts. So the last model that we'll talk about today is going to be the mindfulness model. So the mindfulness model is a lot of times kind of conflated with meditation or this idea of kind of clearing your mind. But what I want you to really focus on is mindfulness has three main components. This is a quote from Jon Kabat-Zinn, who's one of the kind of premier thought experts in mindfulness. So mindfulness is the awareness that emerges through paying attention on purpose in the present moment and non-judgmentally to the unfolding of experience moment by moment. So that has all three of the components that we want to look at. One, paying attention on purpose, deciding that you are paying attention to what is going on. Also, acceptance, having that non-judgmental observation. This isn't about right or wrong, good or bad. It's about just seeing what is happening. And then managing your emotions, not trying to control or change what's happening, but accepting what is going on. So remember, this is about paying attention on purpose to the present moment in a non-judgmental way. Now, the power here is that even though we can't always change what emotions we're feeling or what circumstances we're going on, we can actually get some power out of simply accepting what is happening to us, accepting that we can't always change our circumstances. You can also use mindfulness techniques to work through, issues of doing unpleasant activities. You can change any activity into a mindfulness activity just by deciding that you are going to pay attention to the present moment. I used to really dislike doing dishes, for example, and so what I decided to do was to change that into a mindfulness activity. So instead of focusing on, how upset I was that the dishes were piled up and that my partner hadn't done them and that I had a bunch of other things to do, I decided, no, you know what, I'm going to experience what this is like. So I'm going to feel what it's like to feel my hands dip into the warm water, to feel the bubbles pop against my arm hair, to feel the satisfaction of cleaning a plate, to seeing it get physically clean, to have the cool water run down it as the suds are washed off. And it can really change the experience of that. So it's not just something that I have to do now, but it's something that I can experience, and not necessarily making it a magic, powerful, positive experience, but making it so that it's not something that you dread, not something that is kind of terrorizing you. Mindfulness is a relatively newer field, and so it's something that you are probably going to be hearing more of as you progress through your nursing career, but it's something, again, to just be really familiar with. Make sure, though, that you're kind of keeping it in your mind that this isn't just meditation and having Zen and getting to a state of mindlessness. It is kind of taking control of what your thought process is. Again, paying attention on purpose, non-judgmentally to the present moment, not changing or controlling your emotions, but just kind of managing them, accepting that they're going to be present and letting them be there, not fighting against them. So let's look at our last couple of questions here. So a client with major depression is considering cognitive therapy. The client says to the nurse, "How does this treatment work?" The nurse responds by telling the client, "This type of treatment helps you A, examine how your thoughts and feelings contribute to your difficulties. B, examine how your past life contributed to your problems. C, confront your fears by exposing you to the feared object abruptly. Or D, relax and develop new coping skills." So hopefully everyone got the correct answer as A here. So cognitive therapy helps you examine your thoughts and your feelings and how those maybe are creating difficulties, how maybe those are maladaptive or irrational. Remember, cognitive is referring to the way that we think about things. If we look at option B, this examines your past life and how that's contributed to your problems. It's probably more going to be the psychoanalytical model. Remember that big focus on your earlier life. Confronting your fears by exposing you to a feared object abruptly. One, that is not a good type of treatment, but two, that most closely resembles systematic desensitization. Again, that specific approach, though, is not very good. Systematic desensitization is a very gradual exposure to a feared object, not abruptly exposing you to it. And relaxing and developing new coping skills. This is probably going to most closely be associated with mindfulness. However, that's not necessarily unique to any one treatment, so just kind of keep that in mind. So, last question. Mindfulness encompasses all of the following except A, focusing on the present moment. B, creating bliss and happiness. C, accepting your emotions. D, avoiding judgment. So the correct answer here is going to be B. So remember, mindfulness is not about just creating bliss or happiness. It is about accepting our emotions and our circumstances, paying attention on purpose to the present moment and not judging it as good or bad, just simply accepting it as it is. So for this next part of our discussion, you are going to read a scenario about a patient who is experiencing some interpersonal problems, and you're going to decide what therapeutic approach would be best applied to them. You're also going to select some therapeutic communication techniques that will help you interact with this patient more successfully. That should be the last discussion that you complete in this module. Thank you so much for doing this online week. I will see you all back in class at our clinical orientation on Tuesday the 22nd. Thank you so much. Bye.